You are tuned into the Dr. Tyna Show with Dr. Tyna Moore. For more, visit drtyna.com. On this episode of the Dr. Tyna Show, I am so excited. I got to sit down with the James LaValle. If you do not know who this man is, he is quite literally, in my opinion, the OG of cellular medicine, peptides, metabolic health. I have followed him for years. I've learned so much from him, and I'm so excited we finally got him on the show today. This conversation blew my mind. It may be one of my favorite interviews I've ever done. We just jived on so many things, and we really got to throw down and talk about our opinions of what we think is the current state of metabolic health, what metabolic compromise means to a child born of a mother with metabolic compromise, and what that child's literal cellular health looks like from a very nuanced perspective that I am sure you've never heard before. And we dive into the topic of GLP-1s and what they mean to us and what they mean to medicine overall. This man knows his shit like no one I've ever met. I cannot wait for you to hear this interview. So let's jump in. Jim LaValle, thank you so much for coming on the Dr. Tyna Show. I am so excited to have you here today. I'm a huge fan. You are, in my opinion, like the peptide OG godfather of information. So this is going to be a really, really fun talk. And I know that you are on Team Freedom and Team Medical Autonomy. And I've been to a few of your conferences, so I cannot wait to dig into this with you.
Let's go.
Yeah. All right. So I guess the first thing to start out with is, can you tell the audience a bit about your background? I know it's quite extensive. You've been in this world a long time.
I've been in this area of personalized medicine, precision health since 1984. So it's been a minute in my career watching the growth of this. In that time, taught at the College of Medicine and Pharmacy, University of Cincinnati for 18 years. So did that, precepted it. I had a major clinic in Cincinnati, Ohio, where we were really working with 300 to 400 people a week. And that included a whole spectrum disorder, preconception clinic, working with athletes, working with people with troubled metabolic disorders, everything from metabolic syndrome, diabetes, prediabetes, all that good stuff. And then I spent a lot of time, I would say, in the business world, acting as a consultant for companies like Bayer or P&G or, Thorne Research. I did stuff with them, Numedica, Zymogen, you name it. I've been, a closet formulating for a lot of different companies. And then turned my eyes, did the Pro Football Hall of Fame Performance Health Program. I was the clinical director there and actually chair of the International Peptide Society. Got my second book coming out on that. That one's coming. So I got the updated version. And then also co-chair at American Academy of Anti-Aging Medicine, where I've taught for the last 25 years. And developed Metabolic Code, which is an informatics system that helps put all this information together and helps people make better clinical decisions about what to do. And, I'm working on publishing 3 new books this year. So I think I have some sort of disorder. At least my wife is thoroughly convinced after 26 books and 5 databases that I can't seem to stop.
Gosh.
It's like, stop. I can't.
You're a machine. You're a machine.
I think maybe. And of course, I'm now Chief Science Officer for Lifetime, the big fitness organization. That's I've got 2.5 million lives and 1.5 million memberships that we're designing programs for longevity and performance health. And so I'd say I love to stay busy. What I really love is spreading the word of how people have the right to be well, the right to be fully resilient with their health, and what do they use to do that? And peptides are squarely in the middle of that. I think hormones can be a benefit. I love nutrients. I really am passionate about lifestyle, exercise, making sure you're eating well. And I think it's unfortunate that too early people throw the towel in and they have no idea that they could really live a robust life. I mean, unfortunately, I'm 64 and I would love to live. Oh, no, yes.
I have seen you in real
license.
I've seen you in real life. How are you 64? This is fantastic.
Well, I think it's to our point. I walk the talk. I really believe that you can, because look, my genes are horrible. I'm just telling you, my brother was 476 pounds and listened to me towards the end of his life, but unfortunately passed away early. I will tell you the power of peptides on a personal story, because I think, people think, well, why did you get into doing peptides and what happened, right? Well, the big thing was two things happened. One, my father was diabetic, age 79, has a duodenal carcinoma, has a Whipple surgery at age 79. Whipple at 79, which for those of you listening, they take the lower third of your stomach, the top of your pancreas off, and your duodenum all at the same time. It's a big deal. People usually don't live that long. We applied things like peptides and nutrients and all the things I just mentioned. He lived to 91 from
Wow.
79. And that was the power of taking charge of your health. He wanted to live because he was living with us. He lived in our home and he wanted to be around for his grandson. I would say the other one was my son injured his foot senior year, second level of state playoffs in football. It's a multi-sport athlete, all state in California, which is tough. He had a Liz Frank injury. Usually takes 12 to 18 months to correct that. We applied some peptide therapies to that. He was literally healed after surgery, had surgery. In 5 months, he was spinning on that foot, throwing a discus to win the California State Championship in just 5 months. That would never happen without the power of what was going on with the utilization of peptides as a part of his program. So anyway, that's a couple of quick things as to you might pick up I'm a little passionate. So it's one of those things where those are the things that drive me.
Well, it's so cool because my background was in regenerative medicine. So I was, slinging prolotherapy a long time ago when that was all we had. And then
Right.
we got PRP on board and then stem cells came on the scene. And I was doing all that. And just as peptides were making themselves known in the regenerative medicine space, I was winding down my clinical practice and I was trying to, it was like a 5-year plan to get myself out of practice because I realized that was just not where my passion was. I was really good at what I did, but I just didn't want to trade my time for money or my, like that day to day. I couldn't help enough people that way. So I was leaning more towards online and peptides were showing up and I thought, oh my gosh, like these things are like truly miraculous. And what an incredible piece to put in the puzzle to add to the cocktail that we had available to us. And unfortunately, the powers that be tend to like to come in and squelch anything that works well. So I was right in there when, and it's still always up for debate, but that, the adipose derived stem cell conversation it's still iffy, but it was getting real iffy there for a minute. Anyway, long story short, I left practice and just as the world was being shut down a few years ago, and I'm so glad because I was in Oregon, I would not have tolerated what they were having everyone do. Like I was just not into it. So I'm glad I got out when I did. But then my mentor, truly the one who taught me regenerative medicine, at the end of the day, what he really drilled into me was metabolic health, period. Like he was telling me decades ago, keep your waist circumference in check, keep the belly fat off, don't let your set point get too high. Make sure you back in the 90s, he was telling me to strength train and forget about cardio, like, stop being a cardio bunny. And he was really, I bet you guys were in the same room probably back in the day many times. And he was just such a force of nature and unfortunately passed away from cancer, which is like just it was such a heavy blow to get dealt, and I watched him waste away and then I watched him pass and I ended up taking over his practice because he'd raised me up for it. But all that to say, he would have absolutely loved GLP-1s. He would have thought they were just the missing piece in what we were doing with trying to get people metabolically sound so that they would even respond to the injections. You cannot respond to regenerative injection therapies if you're not metabolically healthy. And you don't have, that was the one defining factor between all my patients was even the guys that were pounding Mountain Dew and garbage food, if they had muscle mass, they healed. And the woman who had the pristine diet and was doing all the things right, but had no muscle mass, she was a much tougher case. Right. And so I learned very early, muscle mass is like the denominating factor, but then muscle mass is only as good as your metabolic health. So
100%.
That's my paradigm. That's where I come from.
I love
So
that. Well, and for me, when I wrote Cracking the Metabolic Code, back in 2002, it was that same concept of we have to manage metaflammation. The story of metaflammation leads to inflammaging. And I think what you said that's so appropriate is where we really hit the crossroads. Like I said, I've been at this 40 years. So watching things, you'd see
I
one
bet.
child when I was a child, I'd see one child in our classroom that was obese. Now we've got 10% of the ped population is projected to be obese. I mean, that's a lot. And so, in the end, one of the things I always told people, because, you get all this uproar about GLP-1s. Oh my gosh, you're going to only lose fat or only lose lean mass. Or you're going to be on it forever. The one thing I've really tried to explain is, when insulin was invented in 1923 as a peptide, everybody cheered because guess what? People didn't die acutely from an insulin deficiency. I think the difference on a GLP-1 is people aren't going to die chronically, right?
Yep.
That side of the signaling of the pancreas and incretin hormones, that's what's leading to heart disease and an enlarged left ventricle of your heart, and why your arteries plaque, and why your brain gets damaged with elevated galectin-3 and elevated lipopolysaccharide. It's all because we can't turn that glucagon engine off. And it's because we've positioned ourselves into that in our culture. And, and I think I really hope that it still stays readily available for folks, that they're able to afford it and they're able to utilize it. But you're so right on about the fact that, like, what we're doing at Lifetime is you got to exercise, you got to eat better, because if you want to maintain your lean mass while you're burning that fat mass, you have to have a full program to really effectively utilize that.
I agree. I agree completely. I think that it's so short-sighted the way that the opinions at large are about GLP-1s in particular, because you and I are coming from, I mean, you're dealing with more of a pathologic, probably group of patients, whereas it was pretty hard to get into my practice. Like you had to go through a bit of a gauntlet, and you really had to come in already metabolically optimized, because if I'm applying these are, payment at time of service procedures, insurance didn't cover them.
Right.
There's people had to pay for them out of pocket. And
Sure.
I thought it was very unethical to apply these therapies to unhealthy people.
Good for you.
The stem cells, the PRP, that stuff's expensive. And I think it was super unethical. I see so many doing it out in practice. It's so unethical to take somebody who's morbidly obese and super inflamed and metabolically compromised and then tell them their stem cells are going to even be worth a damn at the end of the day. And that's not a judgment. It's just how it is. And so I would make people go through an application process to get in. And so they were generally fairly fit and healthy. And I just had to sprinkle a little something to get them optimized.
Right.
But the way that the general public sees GLP-1s, and even a lot of the obesity doctors, is they're dealing with a really pathologic group of people who are really severely metabolically compromised and much further down the trajectory of illness and disease. And so they're applying these really high doses, and they're treating it like monotherapy, and they're sending people off and hey, good luck, here's your pens.
Right.
And I do think there's also this middle ground. There's this middle ground of people who are just ignored. It's you walk into they could enjoy GLP-1s too if done in more personalized dosing strategies, right? And that's what the message I've been trying to get out is there's this forgotten middle, because people are so sick and doctors are so overworked that when someone comes in the clinic like you or I, and they would probably think damn, you're the 1% of your age group, right?
Right.
But if you've got a complaint, or you've got something wrong, or say you've got insulin resistance kicking in because maybe you just dealt with a bad infection, or maybe you had a big stressor in your life or whatever, and that insulin resistance starts up and that glucagon signaling gets off kilter for whatever reason, I think it's appropriate to apply these peptides to sort of nudge the person back into the optimal wellness. And yet everybody's over here screaming that we need to wait until people are just the wheels have fallen off the car. How do you talk about that with people? Because it's almost like two entirely different groups of patients I'm trying to talk about here.
Yeah, I think, the way I put it, you got a lot of people walking into Lululemon buying pants, and they're not losing weight. no matter what they do. They have features of insulin resistance and metabolic inflammation. I mean, platelet volumes up. They got bad actor lipids. Their particle size is off. Their metalloproteinases are up, so their connective tissue's inflamed. They got a whole bunch of stuff going on. They may only be 15 pounds overweight, but that 15 pounds isn't coming off no matter what. I mean, it doesn't matter if they bake themselves in a sauna 20 hours a day, nothing is coming off. And that's because of the power of dysfunctional the glucagon regulation. And so what we've done, what we're doing at Lifetime and what I've done in my clinics that I participate in and what I teach at A4M, we just came back from a 2-day certification course teaching GLP-1s to them is, first of all, you have to have a complete understanding. If people are stress eating because of cortisol or their gut microbiome is really off, they're growing bad bugs, you could give them a GLP-1 and they're probably going to lose weight. And as soon as they're off, they're probably going to gain weight back because you have not looked at a full comprehensive view of what is going on in their metabolism. So that's one. The other piece is that we've taught titration all along, where you start at a very small dose and you only go to the dose where they start losing weight at a rate of about 2 to 3 pounds maximum a week, because we don't want gallstones forming. We don't want them getting dehydrated. And so you have this benefit of that netherworld group that you can manage at lower doses. And then you can also get them off. You can reverse titrate them off if they change their diet, change their lifestyle, know that they need to perform better metabolically. And they may not be dependent on the utilization of a GLP-1 the rest of their life, or they could maybe rely on botanicals that could maybe help them with glucose and glucagon regulation if they're being responsible about stress, sleep, diet, timing of their food, not eating every day, all day. It's about everything you surround that GLP-1 with that I think really creates an effectiveness for the broader part of the population that I think you were talking about. I think you got way more people in that gray area that you spoke of than what we look at traditionally as, oh, you're a type 2 diabetic that's obese, therefore you need this drug.
Yeah, absolutely. And I think there's a place for them outside of metabolic dysfunction. I think actually at the end of the day, everything comes down to some low grade metabolic dysfunction. But I think that even those who don't need to lose any weight, I found a place for them clinically where,
Sure.
we're just trying to maybe have an impact on PCOS or have an impact on
sure.
neurocognition. And, even at tinier doses and just this, it's just about personalized dosing and individual. It's just how we do medicine. That's why it's been so weird to me, because I came out talking about this thinking everybody understood what a compounding pharmacy was and everybody understood what individualized medicine was. And I guess I just have been practicing in a silo for the past 20 years because I had for 30 years, I've been in naturopathic medicine. I'm like, I had no clue that doctors didn't get this. And it's been so odd talking to you. Have a lot more experience teaching doctors on this, but man, inside my course, people really, really want these very specific numbers. And I'm like, there isn't one. It's about the person sitting in front of you. What do they need? What does this individual need? What are your short-term goals? What are your long-term goals? That's what I teach inside my course, because I'm realizing a lot of clinicians don't even have a clue how to address this. Certainly the general public is confused. And anyway, I've sort of created a monster with that term microdose. I know that I didn't create that word, but just talking about it, I got interviewed yesterday by the New York Times, and I was like, I really wish that word weren't out there anymore. It's about personalized dosing. It's about inclusion. It's about the fact that the standard dosing protocols might just be too hefty for some people. And why are we making them go through terrible side effect profiles when we could just create a more inclusive dosing strategy that allows these peptides to be utilized by a broader range of people for a broader range of reasons? I just was reading an article today about knee osteoarthritis, right? And people want to say, oh, it's because they're losing weight. Yes. And when you get osteoarthritis is diabetes of the joint. So when you get metabolic function in check, the knee pain goes down. That is literally my wheelhouse of where my practice was. So it's just been really bizarre. You've been at this a lot longer, but I've been in the field for, at least 30 years at this point. And
You're close to me.
It's been so bizarre to just kind of watch all of this unfold.
I mean, I think the right of compounders to help patients is in real risk. And my mother was a pharmacy technician at the back of a Rexall pharmacy. I used to look up to her and watch her customize, make things for the pharmacist. When I went through pharmacy school, I had to learn compounding. I actually had to learn organic medicinal biochemistry and pharmacognosy. And so the aspect of making things for an individual is just very natural for me to think about that. And in my practice, I mean, my clinic in Cincinnati, I mean, we were seeing 300 to 400 people a week doing all personalized. And, when you do that and you see, first of all, people start to cluster into their problems, right? There's a little bit of a clusterization that occurs, but there's still a need within that clusterization to personalize. And I'm right with you on that. And I think it is tragic that there is so much pressure on compounding pharmacy to be excluded from the value that it adds to healthcare. And I think, for example, compounded semaglutide, compounded tirzepatide. There's no shortage of what the branded drug companies what they're making, and the ability to create a compounded version of these to be able to meet the individual dosing needs of people. I had another personal experience with that. My sister-in-law, we had her on tirzepatide through the clinic. She's doing great. She's down like around 20 units, doesn't need a lot. Well, now she can go because she's classified as a type 2 diabetic. She figured out she could go and get the branded version. Well, then she takes the full dose of the shot, and her blood sugar ends up at 40, and she virtually has a low blood sugar, almost pass out event. And it doesn't make the drug bad that was at that dose. It's just the dose to treat the masses that have the most extreme problem does not meet the needs of that bigger herd, what I call, of people that, to your point, have metabolic dysfunction related to how their glucose and insulin are regulated, which has, in the end, huge downstream inflammatory impact across the whole body. Whether you look at the brain, the joints, the ovaries, the kidneys, the blood vessels, you name it, it's a global impact. And it's why it's so important.
Yep. I remember when I started in practice in 2008, and my colleagues would just give me shit and be like, Tina thinks everybody has metabolic dysfunction, because my mentor, Rick, taught me to look for it in everyone. So I was running those lab panels on everyone. It didn't matter what they came in for. And sure enough, almost everyone did. And this is, how long ago? And now everyone literally has metabolic dysfunction, like 97% of our US. So I watched this happen slowly, and it was like watching a train wreck in slow motion. And
Yes.
the term that even discussing, I was just at a conference for Zymogen, actually. I was just at a conference speaking on this, and you could tell that a large portion of that audience really, at the end of the day, still does not, these are clinicians and healthcare providers, still don't know how to address metabolic dysfunction in their clients and patients. And, I always say, like, when people say, how do I find a doctor like you? I'm like, I don't know, because it's hard to do. But I will tell you, if they don't lift weights, that's probably a sure sign that you don't want to go to them, because at this point, like, if they really prioritize their muscle mass, they at least they know something that the rest don't. And it's not, again, not to throw anyone under the bus, but I'm like, come on, guys, like, this is for real. We need to walk our talk, and we need to show our patients that we know what we're doing. And really, I think the true tragedy and what really drove a lot of what happened in the past several years was metabolic dysfunction at the core, right? Like, that's the fire that kept the fire going. And people don't want to hear it. And they also don't want to believe there's anything they can do about it. And I'm like, actually, GLP-1 or not, like, you got work to do.
Yeah.
Like,
Yeah. I
what's
always
the
tell
work?
people, I was like you, even though I had two populations of people. I mean, I worked on tactical, I worked in, military, worked with athletes in all 5 major league sports. And then I had the pathologic train wreck, and it didn't matter either way. I'd always say to them, look, it's a lot of work to do this with me. We're going to commit to getting to work because it's worth it. It's work, but it's worth it, was kind of my theme statement to people, because there's no easy way. There's no Tibetan goji berries picked in the moonlight, eaten by a lemur, and then the lemur craps it out, and a jaguar takes it and runs it around the jungle and then deposits it to the monk's house. Then the monk makes Tibetan goji berries. They're special. Although I'd really love to get those. I mean, I think it'd be pretty cool. But the point
maybe
being
they'd make us see other worlds.
Yeah, something like that or something. But my point being is, the best peptides. I don't care if you're talking about growth hormone secretagogues that make you lean and help restore your circadian rhythm, immunologic peptides that help to restore balance in your immune system so you're not aggressively attacking yourself or creating too much systemic inflammation, whether it's mitochondrial peptides that are driving all that. All of it is going to be predicated on exactly what you said, Dr. Tyna. Man, you were right on. You got to walk in wanting to have a very healthy body and work at doing that, because there's no doubt you can apply those types of peptides and get people almost like a lifeline to feeling better. But once that starts to kick in, and a lot of times that's the necessary part, right? You get someone feeling better, then they get the momentum, they get the impetus, they get the desire to say, hey, I like feeling this way. I'm going to do whatever I got to do. Yeah, doc, tell me what else I got to do, right? That's what you're hoping for. Because there's no way to get around the fact that, like I said, my second edition of Metabolic Code will be coming out this year, which gets all of this latest information of, cell-to-cell signaling, network physiology, why metabolic health is important, and, obviously inclusive of the value of peptides and small molecules. Really cool small molecule coming out soon called OSO1. I think you're going to go crazy over it when you read about that one.
I'm excited for your book. I'm actually going to start your peptide certification program through A4M this December. I'm finally going to commit to this process.
Yay!
So I'm just trying to sort out all the dates because I'm so excited to dive in, and I think it'll be really great. I know that we've lost some peptides and we've maybe gained some back in the realm that we can prescribe in. Right. So I'm excited to get the latest on all that, because that was such a blow last fall, and it really felt defeating, so I was just kind of like, oh, punch in the gut. It just okay. So speaking of punches in the gut, and then I have a tough question I'm going to ask you too. I'll let you think on it, because I want to talk about childhood obesity. So percolate on that. But what's going on? So we lost in early October, tirzepatide came off the shortage list, which means the compounders lost the ability to, prescribe. Doctors can't prescribe it, and compounding pharmacies, I don't know what's going on there, but it sounds like it's going by the wayside. And then yesterday I found out that semaglutide came off shortage list too. So what do you think the future looks like for these GLP-1s from the compounded versions?
For right now, doctors can still prescribe compounded tirzepatide, and compounding pharmacies can still make compounded tirzepatide. There was a lawsuit that was filed, and basically the suit was cited on the side of the compounding pharmacies that filed it.
Oh, that's right. Okay.
And so you can still get tirzepatide. I think that there could be a rationale within the law that, hey, if I've got concerns of nausea and I want to treat that nausea, I may want a compounded version. Or I think there is enough information coming out on variable dosing that unless the manufacturers come up with a solution to that could also be helpful. The reality is, you've got very big pharmaceutical companies that have invested lots of money into finding these molecules and proving that they work, and they've been on the market for a long time, like semaglutide. And at the same time, one of the moves was, to say, oh, it's demonstratively difficult to make, which, I talked to 5 compounders over the last 5 days that were big into making it. And they just said, no, you can make this stuff pretty easy. It's not that hard to make. And you can guarantee the API or the active principal ingredient that you would make it with. You can guarantee that. So I think it's up for grabs. I'm not sure where it's going to land. I think even I even think pharma's not sure where it's going to land. A lot of it's going to play out in the courts, to be honest with you. And I'm not an attorney. I'm forever hopeful that it remains to be free. But here's what I also know: there'll be other GLP-1s out there that we'll be able to
Yep.
lean on and make more accessible. So as long as we've got accessibility to help with customization for people, I think we're going to be okay there.
Okay, good. That makes me feel better because it's just been it's been a lot actually. And of course, everyone's coming at me asking, and I'm like, this is just so, I mean, this is the opposite of being inclusive, if you ask me. Like, if people can't handle something, then we find a way to find a dose that they can handle. It's not complicated. This is, if these big pharma companies were smart, they would start to figure this out too, because there's a lot of people benefiting, and cost is obviously an issue. And we know that the cost to make these peptides is ridiculously low in comparison to the charge that they are putting upon the US population. And we know that in Canada and in Germany, it's like pennies on the dollar compared to what they're doing here.
That's right.
So at the end of the day, I'm just trying to get good medicine into people's hands. And it's just been bizarre.
It's
the whole
hard
thing's been
because
bizarre.
in general, the cost of drugs in the U.S. is dramatically higher. I mean, Nova makes 90% of their revenue here in the U.S., right? I mean, it's a, and I'm not, what, as you know, like I've been a clinical pharmacist now for a long time, published, taught, all that stuff. And drugs saved my father's life when he had adenocarcinoma, right? So it's okay. All things have value. But I think the issue is that it's the way we're bolstering our economy with these artificial drug prices. I think that's tough. I really do think that's hard, and I'm right with you that people should have drugs that are dosed that are right for them. Any drug should be dosed that is right for them, not just GLP-1s. Anything. Because as you know, you've seen over time, some people just need a fraction of what the typical dose is on even a blood pressure medication. And yet we don't, unless compounding's there to buffer that experience, people are left with having side effects, having adverse events, right? Whereas the correct dose would be much better.
Well, one of the big arguments I get out there from people is other physicians actually is, well, she's recommending dosages that we don't have the data on, and it's not done in the, population that the studies have been done on. And there's no proof. And I'm like, any good doctor that isn't living in a bubble prescribes A, off label, and B, I mean, that's legal, guys. Off label's legal. And B, you break the tablets into halves or quarters if that's what the patient needs. I know many doctors, good allopathic physicians saying, hey, unless it's a time released capsule, with a special coating on it, you can open the capsule and we can put some in applesauce for the children or whatever. Like, this is not a new concept. What I'm proposing is not a new concept in any way, shape, or form. But because it's this pen with this pre-filled amount, suddenly I'm the enemy, and it's been bizarre.
It actually is. But you know what's funny about that to begin with? My argument's always been, we're talking about evidence base. I can name any 3 drugs that you commonly give, and you have no evidence of the 3 of them being given together. So let's just admit we're all swimming around in a big murky pool trying to help people get health, because we don't have that evidence that we think we do. And the other point is, if you look at, so if I give we'll use the term microdose, but let's just say I give a smaller dose of a GLP-1. And their lipids go down, and their insulin and glucose improve, and their kidney function improves, and their metabolic markers related to systemic inflammation go down, and their feet aren't swelling as much, and go on and on and on, right? By default, that's pretty good evidence.
Yeah.
That's
And so long as lab mark, and I also would argue if they're comfortable giving super high doses, how on earth could a tiny fraction of that be more dangerous? Generally speaking, common sense would say it would be less dangerous, right? So if lab markers are moving in the right direction, the patient's finding great benefit, we're in a realm of safety, we're crossing our T's and dotting our I's, I think we're okay. And the other thing I will say is that we don't give a 900-pound gorilla the same dose that we give a 110-pound woman. Right.
Thank you.
This is just medicine. This is how medicine works. This isn't about, people want to split hairs with me on social media because I have a big following. And I'm like, just stop. Like, show me you're a bad doctor without showing me when you ask these stupid questions. Right. Like,
right.
Not you, but you know what I'm saying? Like,
no,
I
totally get what you're saying. And it's interesting because, you know, why are we so hell-bent on giving max doses when we know the number one side effect reported on adverse event reporting through MedWatch, it's nausea and diarrhea.
Yeah.
You know, people are getting overdosed and they're getting the symptoms, and it's so why wouldn't you want to reduce the adverse event reporting by reducing the dose? I mean, there's so many facets of it where I don't know what it is. It's almost like we're trying to change the truth about it. Whereas the rest of the universe, we're comfortable with reducing doses in people and creating quarter tablets and, you know, giving less for a 100-pound person. By the way, that's called pharmacokinetics, right? Oh, I take into account your weight and I administer a drug based on your weight and your ability to clear it. And I don't know. I learned that a long time ago. I guess that word got taken out of healthcare. I don't know. Just trying to figure it out right now. But so that was, I mean, you're just so right on about creating common sense. And I'm kind of with you. It's interesting when I am going to admit something to you. I never even searched my name on social media until about 9 months ago. Like I had no idea I was posted on social media. I'm old school, right? So then my son comes into the company, you know, graduated. He's, you know, all in the new media. And now we're in that. And it's interesting finding that what you said, the splitting hairs over things where I was like, well, if I could give you a 3-hour talk, I would be able to give you my full thought, but I only have 2 minutes, so I can't give you everything I know.
It's so true. I know. They want these complicated answers. I'm like, sure, let me just stop what I'm doing and give you the full hour-long explanation in the DMs. I know. It's wild. I'm so glad, actually. I was wondering because you showed up on Instagram and I was like, yes, he's on Instagram. So I was really excited. That was another reason I waited to get you on the show because I really want to, like, it's the weird thing about Instagram is if people go to your page and you don't have enough followers, they just assume you're not credible. So I was kind of waiting for you to get like a certain amount of that so that people are like, oh yeah, he's here. And you have enough posts, right? If you have enough posts, then people are like, oh, he's here, he's doing it. Because I really want a lot of people to go follow you because your page is so good and you speak such incredible common sense. And it's so lacking in today's medicine. I feel like one of the old dogs in medicine, and I'm not even that. I'm 50. You know, I'm like, this is not. I don't know where common sense went in all of this. And I even have people in our own community. That's been what most bizarre is watching the functional medicine community turn on these peptides and argue with me. And I'm like, are you trying to sell something, guys? Like, what's your beef with this? Or are you just having extreme obesity bias? And like, why, when I talk about it in relationship to Parkinson's and Alzheimer's studies, does everybody have to start screaming weight loss? Like show me your bias, right? It's so bizarre.
Right on. No, even in the fitness space, and I mean, I've been an avid. I mean, I've trained, I've competed. I mean, my garage is a gym, right? I mean, I love training, love training, but when I started talking about GLP-1s at Lifetime, there were people that were angry at me that I wanted to bring GLP-1s in as a part of our program to help people who, no matter what they did, no matter how hard they trained, like I said, no matter how hard they exercised, how well they slept, they wore a ultra human ring, they had their watch on, they're wearing a patch, they're doing everything, and they don't lose a pound. Right?
Yeah. Yeah.
And you know what?
Sometimes there's nowhere else to go. Like you're doing literally all the things and there's nothing else to pull a string on.
Yeah. And honestly, what the crime is not recognizing that because that person's metabolic health is in jeopardy and because we're creating a theosophical decision about a GLP-1, that we're preventing that person from reducing their comorbidities and risks because we have this predisposed thought that, oh, someone's cheating or that's somehow a shortcut. And I got to tell you, you know, the older you get, the harder it is to maintain that lean mass and keep yourself where you need to be. So when you're 25 saying that, it's different than when you're 64 and every age in between, and depending what
Yep.
your metabolic challenges are. And so I likewise kind of have been trying to work through that bias, trying to get the fitness community to understand that you wouldn't take insulin away from someone, right? Oh, hey, you can't use insulin. You wouldn't do that. All GLP-1s are another facet of pancreatic function, because I'm a huge believer that it's not about cortisol. It's not about the gut. All that stuff, when it's all out of balance, it's all about glucose and insulin dysregulation. Whether you have pesticides, metals, mold, overtraining, undertraining,
Yes.
eating too ketogenic, eating too many carbs, whatever it is, it all comes back to people die younger when they lose good pancreatic function and control of their glucose, insulin, glucagon, and the inflammatory response that's around it, right? So it's like, why guilt people about using something? But I'm with you. There's too many people just jabbing it in them with no forward thought about, well, what do I need to do other than take this injection and, hey, I lost weight. They
Yep.
lost lean mass with it, because you will lose. People doing it lose 30% of their lean mass if they're not doing things around it to maintain their lean mass, right? 30 to 40%. And we don't want that.
Yep. Amen.
I knew that was a rant.
That,
I'm sorry.
that was the mic drop. That was it. No, it's everything I've been trying to tell people. So I'm glad you're telling them too, because I keep saying this, and people are not. They're like, "What do I do for mold?" I'm like, "Build more muscle, make yourself harder to compost." What do I do for heavy metals? Like, make yourself more resilient. Like, at the end of the day, it all comes down to, how is your metabolic health? Why are we throwing piles of pills at people and running all these expensive labs when they're clearly metabolically compromised? They can't fight off and go through the chelation or go through the mold treatment when they're in that compromised state. So at the end of the day, get their metabolic health in order. Be harder to kill. Just make yourself harder to kill.
I always say I want to be tough as a 100-year-old shoe leather. That's the way I want to be.
I love that. I love that. Okay, so you've addressed all the things I was going to ask you for pretty much in that rant. So that was good. So we can move on. Let's talk about childhood obesity. Let's talk about
Okay.
epigenetic marking on children of metabolically compromised mothers, and what life really looks like for a child right now who's maybe 10 years old, who's obese, and their parents are probably obese. And all these people over here are screaming that the guidelines, the pediatric American people are misquoting these guidelines so much, saying, oh, because GLP-1's got approved for use for pharmacotherapy in the obese child, that's first line. It's not first line. That's bullshit. But I would love to hear your rant on that.
Wow, this is going to be a big one, because I'm super passionate about this because of our institute where I had a whole spectrum disorder, OB-GYN that ran it with me. She is brilliant. So prenatal, preconception, and then disorders after, right? And look, epigenetically, when a woman's exposed to things, if her microbiome isn't correct, if she is insulin resistant, meaning her blood sugars are up, she's got gestational diabetes, especially when her microbiome's off, that child gets born in a meta-inflammatory state. It's known that first 1,000 days of that child's life is going to influence the way their microbiome is going to form, and likewise how the kind of the intensity, the resiliency, the reserve of their immune system is going to be. And so, the first step is, one is we have to relearn how children should think about eating, right? Parents feed the kids. Kids don't demand what they want. Otherwise, they just have one freezer full of chicken nuggets and bowls of Fruit Loops. That would be it. And so there has to be, it's a complex issue, but there's the epigenetic component of the mother, what they're exposed to from stress, diet, all those aspects that are important. And then the baby gets born, and now things like eosinophilic esophagitis are commonplace, whereas like you'd hear about that once a year 30 years ago, right? Now they got whole hospital wings devoted to it. So you've got to, once that gut microbiome is broke down, You're making a lot of that lipopolysaccharide or circulating endotoxin. So, you get that eosinophilic esophagitis. And then basically what is going on is you're really going to start creating a metabolically inflamed gut, which is the old adage, right? It's diaper rash, eczema, allergies, asthma, autoimmunity. And that process, oh, wait a second, now we're going to add in food sensitivity, right? And then we're going to add in that autoimmune component that's driven by that food sensitivity. And all of that, just so people realize, when once you're metabolically inflamed, to your point, when they have poor metabolic health, and you're making these inflammatory compounds like interleukin 6 and TNF alpha, whole receptor 4 activation, Jack kinase, I can name off a bunch of that stuff. But the bottom line is, you got a bucket of neurocompounds, these compounds, these inflammatory cytokines spilling out into your chemistry. The very first thing that happens, your insulin receptors stop working. You go through what's called IRS1 and IRS2, insulin receptor 1, surface area, and insulin receptor 2. They close down. And now I start to develop what's called aerobic glycolysis, meaning my body now is only going to burn a molecule of sugar is only going to make 2 little packets of ATP. And I make a lot of waste product. And that's when the insulin receptors aren't working. I'm making a lot of waste product. The weight just starts coming on. And so we've got children now who get born with a poor microbiome, who are immediately placed on drugs that alter the pH of the gut because they have to treat the eosinophilic esophagitis. So they're on PPIs, acid blocking meds that change the systemic pH of the gut. And then in addition to that, they're getting sick. So then they get put on antibiotics, which we now know that, the lifetime, and the more antibiotics in your lifetime, the more the comorbidity risk for you as you're aging. And then they're put on allergy and asthma medications. So corticosteroid inhalers and things that like, albuterol, which is a stimulant. So before they get to age 5, they're in a pretty metabolic quandary. And because they don't have much magnesium, they don't have much chromium, they don't have much zinc in their diet, because the last time I checked, chock cola cereal doesn't have those micronutrients in it. They don't have the nutrients that you need to even run an insulin receptor. So to me, it's just tragic that we think that a child playing, on their Xbox is exercise, that we think that we can feed them out of a box if we have the forethought to feed them regularly as they should, as they're growing, and that we don't really address the structural needs of sleep, allowing children to be children, so that the excessive stress of not being able to speak 4 languages by grade 3, maybe you don't have your first, your child doesn't have its first recital by age 6. I'm pretty passionate about, I think we've lost children's ability to be children. And I think that plays into culturally how bad our food is in this country, how many drugs that they get put on, and how exercise is a bad word for that, for children now. Like,
Right.
unless, you can't do that in an organized way in school. So anyway, I don't know if I hit any points for you that we can go through. And never mind the environmental burden, the 300 foreign chemicals found in the umbilical cord of a child at birth now, right? That's a whole nother topic. But that's just kind of a quick run, a quick little run.
It's bewildering, and it's a complicated conversation to have with people. And so you've got people over here screaming, how dare we give a GLP-1 to a child? They just need to eat less and move more. And I'm like,
Whoa.
thinking about everything you just said, realizing, again, I don't have 2 hours to explain this to these people who are screaming with pitchforks, like, how dare we apply a GLP-1 to a child? And I'm like, how dare we not, if they're sitting in this disaster that they're never going to be able to get out of with just diet and exercise alone.
Right.
Yes, we have to address diet and exercise. And the analogy I always make is like, okay, if a house is burning down and it was built with poorly, manufactured materials, inflammatory materials, crappy chemical filled materials that like to burn on fire. Like, yes, we need to have a deep discussion about the foundation of that home and the building materials and the paint and all of the flammable stuff. But also we have a fire right here and I have a fire extinguisher. And you're going to tell those parents and that kid, like, sorry, good luck. Your kid's going to be dead by 25,
Oh,
like,
oh, yeah. Well, what was that
but
data
God
that just
forbid.
came out, right? What was that data that just came out? It was like if you're diabetic before the age of 40, you're going to live 13 less years.
Yep.
I mean,
And
crazy.
data just came out showing that children put on Ozempic had a massive reduction in suicidal ideation. And is it the weight loss? Sure, that's probably part of it, but also the impact that it has on the brain, their neuroinflammation,
Well,
having their insulin regulated for the first time probably ever.
yeah.
That profound impacts on the brain in a positive way. So it's like the pitchfork, it's the Make America Healthy Again crew that's screaming this, and they're screaming erroneous information, in my opinion, because I'm like,
I
you
could not
try
agree
to,
with you more. I thought it was almost naivety. Like my thought when I was hearing them speak was, oh, so you really haven't worked on people. I don't know what else to say. I was like, this is flowery and wonderful. We're going to create food deserts that are now flourishing for people. Right. I mean, in the end, you got microglial activation burning that kid's brain up.
which GLP-1s can put out.
Yes, you and that fire extinguisher. I'm glad I got to tell you something. I'm going to tell you something right now. I am glad I finally got enough followers and got enough input to be on your show because I'm thoroughly enjoying this.
Oh, good. Well, I didn't mean that you needed to qualify. I just wanted to make sure that it was worth
I'm
your
just-
while. So that when I send people to your page, I want them to follow. You know what I
no,
mean? I
I
don't
know.
want
I'm
them to get
kidding.
there and okay, good. Because
I'm just
you more than
kidding.
qualify.
Just kidding. I'm just kidding.
I timed this really well for your benefit, I promise.
Thank you.
So
Thank you.
yes,
I'm
because
really grateful. My son will know what
my
all that means.
followers,
I'm like, I just love,
yes.
I love, I gotta be honest with you. I love when I find colleagues of kindred spirit where we've been through the wars and when you talk to people that have been through enough of this, like you have, like what I have, we kind of come to the same conclusions. And it's like we may have different tactics, pull in different things. But in the end, you kind of start seeing things for what it really is. And it just needs to be heard a lot more.
Yeah, for sure. Me too. I appreciate that because I've been so excited. The first time I heard you speak, I was like, oh, we're going to be friends. This is going to be good. Going back to kids, I don't know what happened for me, but I was a suicidal kid and
Oh,
it was devastating. I had everything. I was smart. I was pretty. I was on the talented, gifted and
yeah.
talented program. And then sixth grade hit and my thyroid fell apart and no one figured it out. And I was
Wow.
that kid. I was that kid that was like pumped with antibiotics and, immune
Yeah.
dysfunction and all, but that was back in the 80s and no one knew what was going on. And, um, the only doctors worth a damn in my life that weren't trying to fill me with pills were my chiropractors. And my
Yeah.
thyroid fell out from underneath me. And I did pull it together through, I got a great best friend at the time. We're still best friends. It's been 40 years. We're best friends. I'm going to go see her next week in Texas. She moved to
Awesome.
Texas. She escaped LA for Texas too. But she, we just started having to walk forever to get anywhere. And so that with all the sun and all the, but we were privileged. We had nice parents that would drive us to the beach in San Clemente. And we had a good life. And so I was able to kind of pull out of that tailspin. But during that period, one of the cardinal symptoms for me with my low thyroid is depression. And so
Right.
it's like the lights go out. You can't, and I don't think a
Sure.
lot of people realize that this is happening to children too. So there was that phase. And then when I hit my teenage years, it happened again. I was 15. It was like somebody just
Wow.
flipped a light switch. And the next thing I knew, I was, hospitalized for suicide. And I so deep, and I had my daughter has had a really difficult time too with depression, and my heart is with these kids
Oh,
and the odds are stacked against them. And if I could sit down and even like what you just said, that rant, if parents only understood what their kids were up against, that
yeah.
even the lean kids, and then we have these, what I think are miraculous peptides, they're just being applied inappropriately in some cases, but in some cases that's the dose people need, right? And if we could just stop with the obesity bias and the everyone thinking it's so easy and actually start to look at what these kids are dealing with, and
Oh,
not to mention what their reproduction is going to be like, if there is even reproduction, right?
possibility.
Like,
Yeah.
right, we're looking at a mess as
Yes.
as a human species. And people are over here arguing whether we should even consider the thought of Ozempic for kids, and I'm like, you have no idea what a shit show is
Oh,
happening
the rest of their
generationally.
life.
Yes, and then their children's life, and it's so disastrous, and people don't want to talk about it because it's so complicated and it's so daunting. And I'm not
Yeah.
saying let's apply it to every child. Like, obviously lifestyle first and foremost always, because like you said, none of this works if you're not doing those things. But
Right.
it really is it's heartbreaking. And I think that for me, just coming out and talking about these peptides has been, I have hundreds of thousands of followers, and I've gotten so many messages from people saying, my doctor was really trying to get me to use them, and I didn't want to because I was so scared by the clickbait
Right.
and the headlines, and that's why I've been just railing against this, because I'm like, I will get the truth out no matter how much shit I have to take. I'm going to tell people the truth about these, because these people then hear my content, they get educated, that education is empowering, and then they turn around, have a conversation with their doctor, they get more appropriate dosing, maybe they go slower, maybe they go lower, maybe they just
Right.
find the dose that works best and they don't have to go all the way up the tree. And
Yeah.
then they write me back and they're like, oh my gosh, it's 9 months later and my life is significantly different.
Oh, good.
They're doing incredible things with their children. They're traveling. They're exposing themselves to things they couldn't do before. Maybe it's just a pain reduction because of the immune modulation. Maybe,
Sure.
who knows? There's a million
Mental
different, there's people
clarity.
who,
My brain's
people stop,
awake.
yeah, people stop drinking, people stop smoking, and they
Yeah.
write me back and say, thank you so much for your content. I listened to all of it. I took it to my doctor. My doctor and I are working on this now, and my life is vastly different. And I'm like, and that we still got this group of people over here. I heard even RFK say something so I don't know if you saw that reel. I commented on it. I rarely do, but he's just parroting whoever's advising him. And he was on some nighttime talk show, and he basically just slammed Ozempic. It was just this eat less, move more kind of gibberish. And I was like, really? Of all the
Come
people,
on.
right? Like this, I've met him. He's a highly intelligent, educated
Right.
guy. And I was like, this is precisely why this continues to be vilified. And it's ridiculous. Anyway, that's my
I
rant.
mean, it is. I have to be honest. I think it's the most significant tool in healthcare to come out in the last 20 years from the pharmaceutical side. I don't know anything that's more important. If you look at a population in the US that's 50% pre-diabetic or diabetic and a trending 50% obesity rate by 2030. I mean, people have to understand when you're pre-diabetic or diabetic, it means you're going to die younger with a lot of unhealthy things happening to you on the way. Kidney failure, amputations, coronary artery disease, plaque, acute heart attacks, right? I mean, there's all dementia, memory loss, cognitive function. I mean, all these things that, I think people just think, well, it shows up. No, it doesn't just show up. It's a byproduct of metabolic dysfunction for 20 to 30 years that nobody helped you figure out so that you could actually live what I said at the beginning of this show, the vibrant, resilient, and healthy life that you deserve, because that's what people deserve.
Yes.
I mean, like I said, watched my brother. I was very sad because I loved him dearly, but watched him, just die young because of obese, got hypothyroid in seventh grade, didn't get the help that he needed, and then had addiction layered on top of it. And boy, would a GLP-1 have been perfect for him?
Yeah, for sure. I'm so sorry to hear that, because I too come from a long lineage of little round apple-shaped people, and I'm the anomaly because I had my mentor. I had Rick. Rick taught
Same.
me early, he taught me in the 90s like how to avoid it, and I have. And I personally pulled out the GLP-1 and for personal use last year, because despite my best efforts, I was getting that middle-aged middle, and I know what that
Yes.
means. And I was in
Yes.
so much pain, and I was getting such terrific brain fog. And I was like, I got to reset the circuit breaker in my house. Like the way
I
that
literally use that same analogy. That's
yes,
fantastic.
like I just needed to, I was like, there's got to be something to pull the lever. And I went down this rabbit hole of research. You were a huge part of that. And I was like, I'm going to try it. And it's been life changing. And it's been life changing for so many people I love and so many people I care about, so many friends and
Yes,
so many followers. And I'm just going to like, I'll die on this sword because I too think it is the most miraculous thing I've seen. It checks off so many boxes. And I know
oh,
there's a lot of great peptides out there, but this one in particular checks off so many boxes. And when available at an affordable price, can be such an incredibly low cost monthly, and maybe even allows folks to do away with a lot of their other pharmaceuticals if done
yeah,
right as part of a comprehensive lifestyle program, right? So I don't know.
hundred
This is the
percent.
drum I'm going to beat.
But I'm
Yeah. Well,
so behind you. I mean, I think I'm just going to be, gonna be on Instagram, just going crazy somehow or another, singing the praises of what you're doing, because you know what? It's it is at the very core. I wrote, and I know we're winding up on time, but I wrote a chapter in a book called Diabetes and Cancer: Epidemiologic Links and Molecular Evidence. It was a textbook, I mean, perfect for nighttime reading, because I mean, it was pretty dense. You opened up a page and you're out, right? But we mapped out. Here's what the thing was: we mapped out all of the progression inside the cell that goes from prediabetes to diabetes. What are all the cell signals, and why do you end up with cancer? And I think that's the other thing people don't understand, is that when you need a GLP-1, you're on the road to having cancer. I
yep.
mean, and that's a fact. I'm not saying anything radical here. It's well known that people with diabetes have a 4 to 8 fold increased risk of various types of cancers, and it's because it screws up the way our body makes energy. I still remember to the day writing that chapter in that book, and then being on the team going through all that, and really understanding, wow, this is what's going wrong in a person's cell. This is why a
Yep.
GLP-1 is so important, right? So I commend you for, I mean, really mean it, for your passion to carry this sword, because we just flat out need more people to get to their ideal weight if they can, at least correct the metabolic inflammation in their body. If it's not a weight issue, it could be a cognitive issue, it could be a pain issue, it could be an addiction issue. And I think that it's critical.
Yes. Well said. I appreciate that. That's the mission, right? It's funny, my mentor always talked about metabolic health, and here I am all these decades later and people still don't seem to understand the severity of it. But to me it's that spectrum, and I'm like, welcome to the rainbow, and at the end of it is cancer. So
That's it.
let's pull every lever we have available to avoid. And there is the whole thing in the peptide community, which I would love to hear your thoughts on this quickly, and then we can close. I keep hearing about how this is just for it's elitism, it's for the exclusive, it's for people who have money. Those are the only people who can access peptides or access doctors who know how to apply peptides. And that's, I don't even know how to respond to that anymore, because I don't think it's true. People have to really start to learn to search and look. That's part of my course, is I have a whole module on how to find a doctor to work with, because if you dig
It's
far enough,
awesome.
you're gonna find success there. But what are your thoughts on that? Because I just don't think that's entirely true. It could be in some circumstances. I think we just need to educate more doctors.
I think that in the end, that's the answer. I know for the International Peptide Society now, I've probably trained over 1,000 docs through that. And not everybody's in an elitist model. I have doctors there telling me when they're getting trained that, hey, my practice isn't, a wealthy practice. I need help figuring out how I can do this for my patients. And they're finding out how they can do it, have more affordable options for people. And by the way, what's more expensive? Managing the complications of, say, diabetes, or taking a peptide that prevents it. You're right. I mean, the average cost is like $13,000 to $15,000 now to manage a person with diabetes. So, the cost ability is there. It's not elite. I mean, what's amazing to me is insulin has been around since 1923. Nobody realizes insulin is a peptide, and it's made very affordable for people. And I do agree with you. This wave is early on, but I believe it's a tsunami. I think that there's no way that we're not going to be able to make this category of drugs, the GLP-1s, more affordable for people, because the evidence just keeps coming more and more that a bigger and bigger population of people will need it. And, and it's going to be needed in varying doses. So I think, I'm with you. No, it's not elitist. We need more docs learning it. And I think the price should come down and should be allowed to be reasonable so that everybody can enjoy the benefits of it.
Yeah, we just need to all be more proactive. So you and I will keep educating, and hopefully it'll keep catching on.
That's right. So, I'm getting my Medicare card this next year. I don't know. I'm not sure.
Shocking. You guys, I've seen him in person. He does not look to be Medicare age. So I'm so impressed. This is the goals. I got to talk to you offline and figure out what I need to do to look like you when I'm 64. So, well, this has been so lovely. I could talk to you for hours. You have to come back on the show, and we'll have to do a round 2 here.
I'd love that. It would be a lot of fun.
Awesome. Well, where can everyone find you? Tell them what your Instagram is. What's the best website? Sure. What's the best place to find you?
The real Jim LaValle is my Instagram. So, and then jimlavalle.com. And obviously, if you're interested in my metabolic programming and what we do, metaboliccode.com. Awesome. That's it. That's basically it. Obviously, Chief Science Officer at Lifetime. They can find my mug there too.
Awesome. We'll make sure all the links are in the show notes for everybody, because those are all great resources. So thank you so much for coming on the Dr. Tyna Show today. It's been a huge pleasure, and I'm so glad to finally meet you. And I can't wait to see you in, I guess, next month at A4M.
Absolutely. I'll be there running that whole show.
All right. Thanks for listening to the Dr. Tyna Show. This is a Wellness Loud production produced by Drake Peterson and mixed by Mike Fry. Theme song is by John the Guild. You can watch the full video version of this podcast inside the Spotify app or on YouTube. As always, you can email the podcast at podcast@drtyna.com. That's DRTYNA. And if you like this episode, please rate, review, and subscribe on your favorite podcast app. You can also find all of my offerings on my website at drtyna.com. For more shows by my team, go to wellnessloud.com. See you next time, and thanks for listening. This podcast is for general informational purposes only. It does not constitute the practices of medicine, nursing, or other professional healthcare services, including the giving of medical advice. I am a doctor, but I am not your doctor. No doctor-patient relationship is formed. The use of this information and the materials linked to this podcast is at the user's own risk. The content on this podcast is intended not to be a substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay in obtaining medical advice from any medical condition they have, and they should seek the assistance of their healthcare professionals for any such conditions.